Hi, I'm Dr. Eisenhauer from the Cardiology Service at Benefis Medical Group. We've received several questions from Facebook and from other social media type access that I thought would be nice to be able to try to answer for you. February is Heart Month, so by all means keep the questions coming, and we would be more than happy to be of support to you and to our community. Remembering, of course, that heart disease is still the #1 killer in the United States today. With that, let me just jump right into some of your questions, and if there's any confusion or any additional questions, just give us a buzz. You're always welcome to make an appointment to come up and see us. We do not require formal referrals from your primary care physician. You can always just feel free to call our office and we'll be happy to meet with you. The biggest part of this question is that you're young and healthy. So we know that the risk of serious heart disease increases with age. In answer to how to judge a particular episode of chest discomfort, that can be a little tricky, and you might want to go see your primary care doctor or make an appointment to come see us. But in general, if these are symptoms that last 1 or 2 or maybe 3 seconds, they're generally not needing to be worried about too much. When we think about angina or true cardiac-related pain, by the book, it really needs to last a couple of minutes or more. It does not have to be associated with exertion. But if there's a symptom that lasts 1 or 2 seconds, or it's associated with taking a breath or doing a particular physical movement and goes away right away, generally we're not very concerned about that type of symptom. Again, in a young and otherwise healthy person. Great question. This is the $1,000,000 question. I frequently tell patients that if I had a pill that made the arteries keep clear and not affected with cholesterol or any other type of vascular disease, I would have 2 Nobel Prizes in medicine and I would have more money than Bill Gates. There simply is nothing that we know of that can completely prevent vascular disease, and that's to include medicines. Now, cholesterol is one of the 5 major risk factors for vascular disease. That is true. The others are diabetes, high blood pressure, smoking, and having a family history of heart disease, particularly if it's a family history of early heart disease, meaning, for say, your parents had their first event before age 55. So cholesterol is one of those major risk factors. Now, calcification doesn't just happen. Calcification in the coronary system, or in any artery in the body for that matter, is a sign of long-term vascular inflammation. It takes that inflammation to attract the calcium that is then deposited. So if you have been told that you have calcium in your arteries, it really does imply that there's been a longer-term inflammation or longer-term vascular disease that you may indeed want to have addressed. Again, addressing can be both primary, meaning we actually physically try to stretch things open, but it can also be secondary to modify those risk factors so that maybe it doesn't get worse quite as fast, or maybe even could stabilize, or maybe even regress a little bit. So calcium is a sign of long-term vascular disease that you may want to address with your physician. Outside of prevention, again, we don't have medicines that can just, like a liquid plumber, clean out your drains, so to speak. Those medicines just unfortunately don't exist. The risk with atrial fibrillation is that there's a somewhat higher risk of stroke. Now, in the age of a person above 70 years of age, there's a 1 or 2% chance of having a stroke per year anyway, irregardless of the atrial fibrillation. Atrial fibrillation, if it either comes and goes or if it's there all the time, can double that risk. So what we really want to do, and the target with the blood thinners, is to reduce the risk from double back down to what's a normal baseline, recognizing we will never be able to reduce the risk of stroke to 0. Now with atrial fibrillation, particularly the kind that comes and goes or might be periodic, if patients are in AFib more than 24 hours consistent, that's when the risk really appears to go up. If someone is in atrial fibrillation for only 15 or 20 seconds at a time, the risk of having higher stroke rates is really not all that significant. So some of this really depends on your type of atrial fibrillation, whether it comes and goes, how long it does stay for before it may resolve, or if you're in atrial fibrillation all of the time, chronically or persistently. Certainly if patients are in atrial fibrillation persistently, meaning long-term, more than a day, 6 months or a year, we're going to prefer that those patients be on a long-term oral anticoagulant or blood thinner, because that does reduce the risk of stroke by upwards of 50%. This is a good question. HDL is the high-density lipoprotein. That's really not the cholesterol component that we're concerned about. We get concerned about the low-density lipoproteins, or LDL, and then the very low-density lipoproteins, or the VLDL. HDL, believe it or not, is actually somewhat protective. So the higher the HDL you are, the better you are, the less risk there is of vascular disease, because the high-density lipoprotein is involved in transporting the cholesterol in the reverse direction out of the vasculature and out of the tissues. So in HDL, there really is no maximum high number. The opposite is really the issue. If you have a low HDL, then that is something that we may need to be more aggressive about treating the LDL and treating the bad cholesterols, because the HDL is not there to balance it out. The ways we do that most commonly is with the statin agents. Things like atorvastatin or simvastatin or rosuvastatin. Those medicines are generally very well tolerated, and they absolutely are associated with stabilizing vascular disease, lowering the bad cholesterol. We don't really have medicines that are specific to raising the good cholesterol or raising the HDL. The best ways we know of to do that are with a balanced diet and with exercise. We know that exercise and weight loss can raise those good cholesterol or HDL levels. Basically, you have been advised by a physician at some point in time to have a procedure done specifically done to your heart. There is no substitute for talking directly with the physicians who do that procedure to start talking about both the indications, the risks, the benefits, and the alternatives to doing that procedure, which is the same with any type of invasive or surgical procedure you might have. So again, I'm not trying to supplant in any way what your cardiologist might be recommending to you, but maybe I can help you a little bit with some of the questions that you have. Cardiac catheterization is a generally safe procedure. By that, I mean that the rate of major complications during the procedure is generally less than 1 out of 1,000, or 0.1%. When you're talking about your heart, I think you might agree that 0.1% is a relatively low risk. The 1 in 1,000 are things like causing you to potentially have a heart attack, even though a lot of people who need cardiac caths may already have had a heart attack, and we're trying to reduce the risk of them having yet another one. There's a 1 in 1,000 chance of probably having a stroke during this, because we are having to pass catheters up through the major vessels below the head and the neck, such that something could, at least in theory, break loose and cause a stroke. There are arrhythmias that can happen, but generally those are very short-lasting. And then the last set of complications is related to where we access your vasculature. To get to the heart, we have to get into an artery and follow the road path to the heart. That can be done in the groin. It can also be done through the wrist. And so depending on that, there may be some vascular access type complications, which are generally limited to localized bleeding. Now, you've talked about needing a potential stent put in your heart. That would imply that if they do the angiograms and find a blockage that is severe, By that I mean it limits the amount of blood flow downstream past that blockage. A stent is a stainless steel, sometimes made out of platinum, sometimes coated with drugs, sometimes not. It's a mesh tunnel that goes in deflated, and then you literally expand it inside that stent, inside the artery, and leaves a tunnel behind so that it scaffolds and holds that artery open. Stenting is generally very, very safe. Okay? There is a less than 3 in 1,000 chance that it may be complicated or that the artery they're working on in the heart could actually tear or rip. That is one reason why still to this day we talk about whether or not there's an operating room and there's a heart surgeon available to back you up in case something goes wrong. So the rates of that are really quite small, but if that happens, it can be a pretty big deal. So generally, all cardiologists who do this procedure have a plan in place of what to do in the what-if scenario, or the oh-no situation, something went wrong. Certainly here at Benefis, we have that capability. We have CT surgeons. We have operating rooms should that happen. At the same point in time, I can tell you that it's been several years since that has happened at our hospital. The rate of it needing to be done is very, very low, and somewhat surprisingly low. So if you take all of those risks and pile them together, that means there's about a 99.5 to 99.6% chance that you'll go through the procedure and be just fine. 0.4 to 0.5% that there could be a complication, might be minor, could be unfortunately major. So again, I would recommend you go back and talk to the actual cardiologist who does that procedure, who may be counseling, because he may know more about your specific case and what kind of risk parameters you may be dealing with. Pacemakers are frequently located under the skin up in the chest area right below your collarbone. They're usually outside the muscle, but yet underneath the skin and the fatty tissue that's right underneath the skin. So it's very common to be able to feel your pacemaker or even be able to see it. Okay? Couple of key things with this. Number one, please don't play with your pacemaker. If you sit here and play with it and push it around and do things, you can break the wires, you can move it, you can flip it, you can do all sorts of things that can ruin the pacemaker and make it such that we have to take it out and put in a new one. So if you have a pacemaker in place, it's okay to scratch it or whatever, but try not to play with it too much. Now, if you note that the skin breaks down above that pacemaker, that's a pretty big deal. We don't want skin breakdown if your pacemaker is red or swollen, or there's red streaks coming from it, or if there's fluid leaking from that area, or even pus coming from that area. That is a quasi-emergency. We need you to go see your cardiologist because there may be a problem that needs that pacemaker to be replaced. Now, in terms of just muscle discomfort from around that area, if it's associated with musculoskeletal movement or extending your arm, that's pretty uncommon, number one, but there often isn't much that we can do about it because there is scar tissue that does happen around where that pacemaker is located. That said, if it's debilitating or limiting in any way and it's preventing you to do the kind of things that you need to be doing, it is perfectly acceptable to go see your cardiologist and maybe a revision can take place. There are some older pacemakers that still transmit electricity through the muscles down to the heart or back from the heart to the pacemaker itself. Those are very uncommon nowadays, but every once in a while feeling a twitch next to your pacemaker can be a normal thing. Pain is never normal. So if you are feeling pain, whether it be intermittent or whether it be consistent, go see your doctor. Pain is not normal. The normal heart rates actually are between 60 and 100. We don't really consider a heart rate to be abnormally fast unless it's persistently above 100 or 105 or even 110 in certain circumstances. Certainly when you exercise or if you're active or mobile, it is expected that your heart rate will go up transiently. A heart rate should go up when you move around, but then it should come back down gradually to between 60 and 100. So in that regard, a heart rate of 98 is really nothing to be terribly concerned about. Now, in this question, you did admit that you were slightly overweight. That is associated with a higher resting pulse. Okay, it kind of is a sign of maybe a little bit more deconditioning or a little bit not in as good a shape as maybe you might be. So with weight loss, and particularly with exercise, you can drop your resting heart rates down. But in the absence of dizziness or lightheadedness or maybe feeling like you might pass out, I would not be concerned about a heart rate of 98 all that much. Now, the other thing to recognize is in this question you said you notice it at night. It's very common to be more aware of what your heart is doing at night when things are quiet or when you're laying down in bed, or particularly when you're laying on your left side down in bed, because the heart kind of swings over to the left side of your chest and you can actually sometimes feel it through your chest. So again, the fact that it happens at night versus during the day really doesn't bother me all that much. You're probably just aware because you're more quiet or you're maybe in a different physical position than you might be during the day. That's a very good question, and we are frankly still learning about the cardiac effects of COVID-19. The book is literally still being written. Research projects are underway. There are registries that are in place where we are tracking the progression of disease because frankly we don't really know yet what to tell individual patients about their recovery. COVID-19, as you may be aware, is primarily a pulmonary or a lung-type respiratory virus, but there certainly are cases where the virus can cause either pericarditis, which is the tissue around the heart, to become inflamed, or myocarditis, where the muscle of the heart itself becomes involved with the COVID virus and becomes inflamed. If you were told your heart is enlarged, the next question is, how did they know that? X-rays are notoriously less reliable to tell about size of the heart. So if you've been told that based on a physical exam or on a simple X-ray, I would say that's probably not enough information. We do ultrasound testing of the heart, basically sonar of the heart, and we can measure the dimensions of the heart itself. We can see how the heart moves and how the valves open and close and how the different sections of the heart contribute to its overall function. That really is the gold standard study. So if you're concerned about your heart being swollen and you haven't had an ultrasound of your heart, go to your primary care doctor and see if they might be interested or willing to get that for you. Now, once we determine that a heart is perhaps not working as efficiently as it should, and in a patient who has a proven history that they've had COVID, we are watching those patients pretty closely. Even though we don't have practice guidelines published right now, we are learning from the American College of Cardiology and our other national organizations that those patients probably need to have a repeat ultrasound done in 60 to 90 days. And a section of those patients may even need more advanced imaging, for example, with a cardiac MRI study or magnetic resonance imaging scan. That's a clinical decision. Certainly not every patient needs to have advanced imaging, but if things are not recovering the way we might want them to, perhaps we might be interested in doing that. You may be aware that there are protocols in place for professional athletes and collegiate athletes where they're all getting MRI studies. Those registries, we're still trying to learn what to do. Generally, if we do see that there's weakening of the heart and we think it's from COVID, we do a couple of things. One, we'll probably put you on some medicines to help the heart relax better. Number two, we'll be more aggressive about treating your blood pressure to make sure it's not elevated. And number three, we're probably likely to tell you to kind of cool it a little bit. We don't need you to be out there trying to be an Olympic athlete. You probably don't need to be doing weightlifting. It's okay to go out and go on walks for 30 minutes 3 or 4 times a week, but you don't need to go out and train for a 5K or a half marathon when you have active COVID disease of your heart. That's probably not a good idea. Now, we expect that it will resolve. We don't know exactly yet the timeline of, say, 3 months, 6 months, a year. We're still learning that process. But our full expectation is that this is a reversible cause for the myocardial inflammation. We'll just want to watch you pretty closely to make sure that it does reverse. It's been my pleasure to visit with you today and answer your questions. It certainly would also be my pleasure to see you in our office. I have 6 colleagues here that are cardiologists. There's some nurse practitioners here. We have vascular surgeons. We have cardiac surgeons. We have a pretty broad spectrum of capabilities here at Benefis Heart and Vascular. So again, if you have any questions after our program today, please don't hesitate to give us a call. We'd be more than happy to see you in our office. Again, referrals from your primary care office can sometimes speed the process, but we don't specifically require that.